Okay, let's talk about the patient with elated or irritable mood, starting from the case summary. Okay, feeling that she was no longer able to cope, Mrs. E.M. consulted her general practitioner about a mental health act assessment for her husband, Mr. E.M., a 37-year-old freelance writer. He had no psychiatric history rather than a period of depression 2 years ago. He had progressively needed less sleep over the past 2 weeks and had not slept at all for 48 hours. Recently, he had started taking on increasing amount of work and seemed to thrive on this due to an inexhaustible source of boundless energy. He told his wife and all his friends that he had a new lease of life, as he was happier than ever. Mrs. E.M. became concerned when he developed lofty ideas that he was a world expert in his field, remaining convinced of this even when she tried to reason with him, and would talk insistently, incessantly for hours about elaborate and complicated writing schemes. Mr. E.M.'s behavior had become markedly uncharacteristic over the past day or two, when he started making sexually inappropriate comments to his neighbor's wife and presented her with reams of poetry which he had spent the night writing. When Mrs. E.M. suggested that he visit the GP, Mr. E.M. became verbally aggressive, saying that she was trying to bring him down because she was threatened by his irresistible sex appeal and wit. Mrs. E.M. was unable to reason with him and noticed that he struggled to keep to the point of the conversation, often bringing up issues that seemed completely irrelevant. The GP noted that, other than a recent bout of flu, Mr. E.M. had no medical problems and was not using any prescribed medication. He denied using drugs or alcohol. For a discussion for the case study, see the end of the chapter, inshallah. Okay. Just as spells of feeling sad and miserable are quite normal to the human experience, so too are periods where we feel elated, excited, and full of energy. Although an irritable or elevated mood is not in itself pathological, it can be when grossly and persistently so, and when associated with another psychopathology. Definitions and clinical features. In Chapter 11, we will observe how a disturbance in mood, in addition to various other cognitive, biological, and psychotic symptoms, all contribute to the recognition of depressive episode. A similar approach is taken to hypomanic and manic episodes. These occur on the opposite pole of the mood disorder spectrum to depression. Core symptoms. The International Statistical Classification of Diseases and Related Health Problems, 10th edition, ICD-10, classification system specifies two core symptoms of manic or hypomanic episode. First, sustained elated, irritable, or expansive mood. Second, excessive activity or feelings of energy. So, elated, irritable, and expansive mood, or with excessive activity or feeling of energy. When manic and depressive symptoms rapidly alternate, for example within the same day, this is termed a mixed affective episode. Okay. Mood. The hallmark of hypomanic or manic episode is an elated or irritable mood. Patients often enjoy the experience of elevated mood and might describe themselves as feeling high, on top of the world, fantastic, or euphoric. This mood has an infectious quality, although those who know the patient will clearly see it as a deviation from normal. However, some patients tend to be extremely irritable or suspicious when manic and do not enjoy the experience at all. They have a low frustration tolerance, and any thwarting of their plans can lead to a rapid escalation in anger or even delusions of persecution. What about increased energy? This initially results in an increase in goal-directed activity, and when coupled with impaired judgment, can have disastrous consequences. For example, patients may instigate numerous risky business ventures, or go on excessive spending sprees, or engage in reckless promiscuity that is unusual for them. However, in severe episodes, actions can become repetitive, stereotyped, and apparently purposeless, even progressing to a manic stupor in the extremely unwell. If left untreated, excessive overactivity can lead to physical exhaustion, dehydration, and sometimes even death. On mental state examination, increased energy can be seen as psychomotor excitation. The patient is unable to sit still, frequently standing up, pacing around the room, and gesticulating expansively. Hints and tips. Patients with mania experience irritability 80% or labile or fluctuating mood 69%, just as often as euphoria 71%. Let's talk about biological symptoms. First, decreased need for sleep. This is a very important early warning sign of mania or hypomania. Sleep disturbance can range from only needing a few hours of sleep a night to a manic patient going for days on end with no sleep at all. Crucially, it is not associated with fatigue. Hints and tips. Irrespective of how obvious the diagnosis might appear, it is always important to routinely examine for affective symptoms such as a decreased need for sleep in 81%, grandiosity in 78%, racing thoughts 71%, distractibility in 68%, and sexual disinhibition. Let's talk about cognitive symptoms. We have elevated sense of self-esteem or grandiosity. Hypomanic patients may overestimate their abilities and social or financial status. In severe cases, manic patients may have delusions of grandeur. We will talk about them. Poor concentration. Manic patients may find it difficult to maintain their focus on any one thing as they struggle to filter out irrelevant external stimuli, background noise, other objects, or people in the room, making them, as a consequence, highly distractible. Accelerated thinking and speech. Manic patients may subjectively experience their thoughts or ideas racing even faster than they can articulate them. When patients have an irrepressible need to express these thoughts verbally, making them difficult to interrupt, it is termed pressure of speech. When thoughts are rapidly associated, when thoughts are rapidly associating in this way, in a stream of connected but not always relevant concepts, is termed as flight of ideas. Some hypomanic patients express themselves by incessant letter writing, poetry, doodling, or artwork. This is for accelerated thinking and speech. Communication. Assessing manic patients can be made difficult by their distractibility and disinhibition. Adopt a polite but firm approach and redirect the patient back to the questions you need to ask. Another cognitive symptom, which is impaired judgment. Impaired judgment, and insight. This is typical for manic illness and sometimes result in costly indiscretions that patients may later regret. Lack of insight into their illness can be a difficult barrier to overcome when trying to engage patients in essential treatment. What about psychotic symptoms? Psychotic symptoms are far more common in manic than in depressive episodes and include disorders of thought form, thought content, and perception. So, thought form, thought content, and perception. Disordered thought form commonly occurs in schizophrenia but is regularly seen in manic episodes with psychotic features, and to a lesser degree in psychotic forms of unipolar depression. The most common thought form disorder in mania are circumstantiality, tangentiality, and flight of ideas. However, signs of thought disorder, most typically of schizophrenia, can also be seen in manic episodes like loosening of association or neologism and thought blocking. Circumstantiality and tangentiality. Circumstantial or over-inclusive speech means speech that is delayed in reaching its final goal because of the over-inclusion of details and unnecessary asides and diversions. However, the speaker, if allowed to finish, does eventually connect the original starting point to the desired destination. Circumstantiality need not to be pathological. Most families have at least one person who takes forever to finish a story. Tangential speech, on the other hand, is more indicative of psychopathology and sees the speaker diverting from the initial train of thought, but never returning to the original point, jumping tangentially from one topic to the next. Flight of ideas. As described earlier, flight of ideas occurs when thinking is markedly accelerated, resulting in a stream of connected concepts. The link between concepts can be as in normal communication, where no idea follows directly on from the again. The link between concepts can be as in normal communication, where one idea follows directly on from the next, or can be links that are not relevant to an overall goal. For example, links made through wordplay such as pun or clang association or thought, some vague ideas which is not part of the original goal of speech. For example, I need to go to bed now. Have you ever smelt my bed of roses? Ah, but a rose by any other name would smell just as sweet. Even though manic patients may appear to be talking gibberish, and written transcript of their speech will usually reveal that their ideas are related in some, albeit obscure, way. As patients become increasingly manic, their associations tend to loosen as they find it increasingly difficult to link their thoughts. Eventually, they approach the incoherent thought disorder, sometimes seen in schizophrenia. Abnormal beliefs. Patients with elated mood will typically present with grandiose delusions in which they believe they have special importance or unusual powers. Persecutory delusions are also common, especially in patients with an irritable mood, and often feature them believing that others are trying to take advantage of their elated status. When the content of delusions matches the mood of the patient, the delusions are termed mood congruent. Very often, patients with elevated mood may have overvalued ideas as opposed to true delusions, which are important to distinguish, as the former are not regarded as psychotic in nature. About perceptual disturbances, some hypomanic patients may describe subtle distortions of perception. These are not psychotic symptoms and mainly include altered intensity of perception, such as sound seems louder, hyperacusis, or colors seem brighter and more vivid, visual hyperesthesia. Psychotic perceptual features develop when manic patients experience hallucinations. This is usually in the form of voices encouraging or exciting them. Hints and tips. Always screen for psychotic symptoms in patients suffering from a manic episode. A prevalence is very high. 2/3 report experiencing psychotic symptoms during such an episode. Interestingly, only 1/3 report psychotic symptoms during a depressive episode. What about the differential diagnosis for patients with, elated mood and so on? Like depression, an elevated or irritable mood can be secondary to a medical condition, psychoactive substance use, or other psychiatric disorder. These will have to be excluded before a primary mood disorder can be diagnosed. Here we have a box that shows the differential diagnosis for patients presenting with elevated or irritable mood. So this is the box, differential diagnosis for patient presenting with elated or irritable mood. We have mood disorders like hypomania, mania, mixed affective episode, isolated episode, or part of bipolar affective disorder. We have cyclothymia as a differential. Depression may present with irritable mood, of course. Another differential is like secondary to a general medical condition or secondary to psychoactive substance use. These symptoms may be part of psychotic disorders like schizoaffective disorder that may be similar to mania with psychotic features. It may be part of schizophrenia. Another differential is personality disorder with prominent traits of disinhibition, negative affect, or dissocial features. Neurodevelopmental disorder is another differential, like attention deficit hyperactivity disorder. Delirium and dementia would be also a differential here. Let's start with the differential diagnosis. First, mood affective disorders, like hypomanic, manic, and mixed affective episodes. The ICD-10 specifies 3 degrees of severity of manic episode: hypomania, mania with psychotic symptoms, and mania without psychotic symptoms, and mania with psychotic symptoms. Again, we have 3 degrees: hypomania, mania without psychotic symptoms, and mania with psychotic symptoms. All these share the above-mentioned general characteristics, most notably an elevated or irritable mood, an increase in the quantity and speed of mental and physical activity. If psychotic symptoms are present, the episode is by definition mania. In those without psychotic symptoms, the distinction between mania and hypomania can be hard to judge and hinges on the degree of functional impairment. If the person is experiencing rapidly alternating, for example, with few hours of each other manic and depressive symptoms, they are diagnosed with a mixed affective episode. Okay, here we have this algorithm that's good to diagnose mood, elevated, irritable, or labile mood. Okay, so if we have functional impairment, if with minimal interference with work or social activities, here we consider no mental illness, or maybe cyclothymia and other differentials. If we have considerable interference with work or social activities, it may be some kind of hypomania. If we have complete disruption to work or social activities, for example, that needs admission, we ask ourselves if we have psychotic symptoms. If no, this is mania. If yes, we have psychotic symptoms, this is mania with psychotic features. So this is mania with psychotic features. Bipolar affective disorder. Most patients who present with a hypomanic or manic or mixed affective episode will have experienced a previous episode of mood disturbance, depression, hypomania, mania, or mixed. In this case, they should be diagnosed with bipolar affective disorder. Most patients who experience hypomanic or manic episodes also experience depressive episodes. Hence, the commonly used term manic depression. However, patients who only suffer from manic or hypomanic episodes with no intervening depressive episodes are also classified as having bipolar affective disorder. even though their mood does not swing to the depressive pole. It is good practice to record the nature of the current episode in a patient with bipolar affective disorder. For example, bipolar affective disorder, current episode manic without psychotic features. Cyclothymic disorder. Cyclothymic disorder or cyclothymia is analogous to dysthymia in that it usually begins in early adulthood and follows a chronic course with intermittent periods of wellness in between. It is characterized by an instability of mood over at least 2 years, resulting in alternating periods of mild elation and mild depression, none of which are sufficiently severe or long enough to meet the criteria of either a hypomanic or a depressive episode. Cyclothymic disorder or cyclothymia. So that's it about that. Depression. There are 3 common scenarios where a patient with primary depressive disorder may present with an elevated or irritable mood. An agitated depression can present with prominent irritable mood, which when coupled with psychomotor agitation can be difficult to distinguish from a manic episode. Depressed patients who are responding to antidepressant or electroconvulsive therapy may experience a transient period of elevated mood, and a patient with a recently resolved depressive disorder might misidentify euthymia for hypomania. Another differential diagnosis is manic episodes secondary to a general medical condition or psychoactive substance use. A medical or psychoactive substance use of mania should cause mania. A medical or psychoactive substance cause of mania should always be sought for and ruled out. Here we have a box that lists the medical and the substance causes of mania. Medical conditions like cerebral neoplasms, infarcts, trauma, infection including HIV, autoimmune encephalitis. All of these are some of medical causes of mania. Cushing disease, Huntington disease, hyperthyroidism, multiple sclerosis, renal failure, systemic lupus erythematosus, temporal lobe epilepsy, vitamin B12 and niacin pellagra deficiency, substances like amphetamine, cocaine, hallucinogens, novel psychoactive substances, prescribed drugs like anabolic steroids, antidepressants, corticosteroids, dopaminergic agents like L-Dopa and Silgaline, bromocriptine. The medical condition or substance use should predate the development of the mood disorder, and symptoms should resolve with treatment of the condition or abstinence from the offending substance. Absence of previous manic episodes and lack of a family history of bipolar affective disorder also supports this diagnosis. Schizophreniform is another differential. Schizophreniform disorders. We have in this book, when we talk about schizophreniform disorders, we are talking about disorders that are like depression, like schizophrenia and related disorders, let's say. It's not schizophreniform disorder that is described in DSM-5, which is schizophrenic symptoms within 1 month, from 1 month to 6 months duration. No, here we are talking about schizophrenia and related disorders like schizoaffective disorder and schizophrenia. So, schizoaffective disorder is the differential here. This can be very difficult to distinguish from a manic episode with psychotic features. Schizophrenia is another differential here. Patients with schizophrenia can present with an excited, suspicious, or agitated mood, and therefore can be difficult to distinguish from manic patients with psychotic symptoms. Here we have a table that compares relevant features that might act as clues to the correct diagnosis. So here we have the psychopathological distinctions between mania and schizophrenia. These are guidelines only. Typical schizophrenic symptoms can occur in mania and vice versa, of course. So the pathology about thought form. In mania, it is usually circumstantiality, tangentiality, and flight of ideas. While in schizophrenia, we are talking about loosening of association, neologism, and thought blocking. Delusions in mania, most often mood congruent, grandiose delusions or persecutory delusions. While in schizophrenia, we are talking about delusions that unrelated to mood, bizarre delusions usually, delusions of passivity, thought insertion, withdrawal, broadcast, and so on. Speech. Pressured speech that are difficult to interrupt, while in schizophrenia, speech is often hesitant or halting. Biological symptoms. In mania, significantly reduced need for sleep, increased physical and mental energy, while in schizophrenia, sleep less disturbed and less hyperactive. Psychomotor function is agitated in mania. In schizophrenia, that may be agitated, catatonic symptoms, or negative symptoms. Okay, that's it about schizophrenia. Let's go to another differential. Personality neurodevelopmental disorders. Personality and neurodevelopmental disorders. Patients with disorders of personality or neurodevelopment often report features similar to hypomania, for example, impulsivity, displays of temper, and lability of mood in personality disorder, with prominent features of negative affect, disinhibition, or dissocial features. Or in attention deficit hyperactivity disorder. However, personality and neurodevelopmental disorders involve stable and enduring behavior patterns, unlike the more discrete episodes of bipolar affective disorder, which are characterized by a distinct, demarcated deterioration in psychological functioning. Further, mood instability in personality disorder or neurodevelopmental disorder tend to fluctuate more rapidly. For example, from hour to hour. Okay, we'll talk about these in chapter 17 and 18. Another differential diagnosis is delirium. Insomnia, agitation, and psychotic symptoms in an older adult can be a presentation of hyperactive delirium or of behavioral or psychological symptoms of dementia. Okay, how we assess these patients? Starting from history. The following questions might be helpful in eliciting the key symptoms of mania and hypomania. Have you been feeling particularly happy or on top of the world lately? Do you sometimes feel as though you have too much energy compared with people around you? Do you find yourself needing less sleep but not getting tired? Have you had any new interests or exciting ideas lately? Have you noticed your thoughts racing in your head? Do you have any special abilities or powers? In examination, a basic physical examination including a thorough neurological and endocrine system examination should be performed on all patients with elevated mood, to rule out physical problems, medical problems, and substance use. Investigations. As for the depressive disorder, social, psychological, and physical investigations are normally performed on manic patients to establish the diagnosis and to rule out an organic or substance-related cause. Here we have a box to talk about. We've talked about that actually. A urine drug screen is essential in anyone presenting with a first episode of elated mood. Let's talk about this algorithm for the diagnosis of mood disorder. Okay, here it is. Let's start from the beginning. So, if we have a patient with depressed, elevated, or irritable mood, we ask ourselves, is these changes depression, elevated or irritable mood, are secondary to a medical condition or psychoactive substance? If yes, so organic mood disorder or substance-induced mood disorder. If no, we ask ourselves, and we investigate, of course, about these symptoms if that occurs simultaneously with schizophrenia-like symptoms. If yes, we are talking about schizoaffective disorder. And in DSM-5, we have this duration of 2 weeks of psychotic symptoms without mood symptoms to differentiate schizoaffective disorder from bipolar disorder. Okay, then we ask ourselves this question: what is the nature of the current mood episode? What is the nature of the current mood episode? Is it something else? Okay, if we are talking about depressive episode, okay, after we rule out all of these things, it's not organic or substance induced, it's not schizoaffective, we ask ourselves about the nature of the current mood episode. So if we are talking about a depressive episode, has there been a previous hypomanic or manic or mixed episode? If no, has there been a previous depressive episode? And if yes, we are talking about recurrent depressive disorder. Recurrent depressive disorder. Okay, if these episodes are hypomanic episodes or manic episodes or even mixed affective episodes, we ask, has there been a previous depressive, hypomanic, manic or mixed episodes? If yes, we are talking about bipolar affective disorder. If this mood episode is chronic low-grade depression or cycles of mild elation and mild depression, we are talking about dysthymia. If this is just depression, mild depression, or cycles of mild depression and elation, we are talking about cyclothymia. So this is good. Okay, discussion of case study. The case summary that was at the beginning of this chapter, this is the discussion for that. Okay, so you can get back to that to refresh your memory, but we can continue with the discussion. Mr. EM appears to be suffering from a manic episode with psychotic features. He has an elated mood and has developed the grandiose delusions that he is a world expert. Mood congruent psychotic symptoms. Note also the rapid switch or irritable mood when confronted. Biological symptoms include the reduced need for sleep and increased mental and physical energy with overactivity. Cognitive symptoms include elevated sense of self-importance, poor concentration, accelerated thinking with pressure of speech, and impaired judgment and insight. The episode is classified as manic episode, of course. Okay. Because of what? Because of the severe impairment in social and probably work functioning, and because of the psychotic features. Although Mr. EM denied using drugs or alcohol, intoxication with substance like a novel psychoactive substance is an important differential. A urine drug screen could exclude amphetamines, and a collateral history might help to identify any existing pattern of substance use. However, the long duration of symptoms, 2 weeks, is less suggestive of substance-induced manic symptoms, which would typically resolve over a few days. Okay. The past psychiatric history is extremely important in this case. A previous mood episode, hypomanic, manic, depressive, or mixed, is required in order to make the diagnosis of bipolar affective disorder. Mr. EM had a period of depression 2 years prior to developing this manic episode, suggesting the diagnosis is bipolar affective disorder, current episode manic with psychotic features. Previous psychotic episodes would add schizoaffective disorder and schizophrenia to the differential diagnosis. Now we can go to chapter 22 to read about the mood disorders and their management. Chapter summary. A manic episode is a sustained period, at least a week, of extremely elated or irritable mood associated with increased activity and energy. A hypomanic episode has the same symptoms as a manic episode, but without marked impairment in functioning. A mixed affective episode is the rapid alteration between symptoms of mania and depression over a sustained period, at least 2 weeks. Psychotic symptoms can occur in mania, generally mood congruent. Bipolar affective disorder is diagnosed when episodes of mood disorder recur. The key differential diagnoses for an episode of elated mood are substance use disorder or psychotic disorder. When assessing someone with elated mood, ask about the 4 domains of core symptoms, biological symptoms, cognitive symptoms, and psychotic symptoms. هذا والله تعالى أعلم، وصلى الله وسلم على سيدنا محمد وعلى آله وصحبه أجمعين.